Good evening, everybody, and thank you for being here with me this evening or night for a short webinar, but I think interesting and interactive webinar about the current concept on implant maintenance with PIEZON PI. So my name is Magda Menzi. I'm a periodontist and a professor of periodontology and oral surgery in Brescia, Italy. At the Brescia University, and I teach to both dental hygienists and dentists. My topics in my research activity are concentrated on non-surgical treatments of periodontitis and peri-implantitis since a long time, and I have been working in cooperation with EMS and EMS technology and protocols since a long time, more than 10 years. And with my group, we had created a lot of randomized clinical trials and research in vivo and in vitro using the erythritol powder, the PeriFlow, the airflow, the PIEZON PS, and the PIEZON PI. And now I had the opportunity to test and use as an opinion leader the PI Max, and I'm really happy to share with you, with my colleagues, the clinical experience and ideas and the first feeling with the new tip. And I was one who really needed something new for the maintenance of implants, healthy implant, and the treatment of mucositis, and also for different other clinical indications, so to remove pigmentation or have deposits around on all or on ceramic veneers, for example, or global restoration of the mouth with ceramic and zirconia, and sometimes I had some problems because the old instrument was not so effective or too big or not able to reach specific micro area. So let's start with the concept. So what is success in implantology, and why we want to maintain this kind of stability? So aesthetic, good soft tissues, no problem on the prosthesis, but also no suppuration, no bleeding and probing, no deep pocket around those kind of restoration. So the success is this in terms of aesthetics, but is this in terms of bone stability, and is this in terms of soft tissue stability. And this is due to particular shapes of the crown. So as you can see here, we have a convex emergence profile to maintain, to press, and to help the soft tissue to have a gripping on the aesthetic materials. And here is convex, and here is straight. This is the shape that we need to have, and it is really difficult and really peculiar to have these kind of shapes, because to obtain and to get and to maintain the aesthetics, we are obliged to have this kind of difficult shape to check, to clean, and to maintain. So we need to be focused on those kind of shapes and try to think how to check and how to maintain, and which instruments will be the better to maintain this structure. And why we need to do that? Because the periodontal supportive therapy in patients with implant is fundamental to maintain the success during the time. In fact, we have an incidence of peri-implant complication about of 31.2% up to 43.9% in patients without periodontal supportive therapy, but we can reduce to 80% if we offer a periodical recall to the patient, and we teach to the patient how to maintain at home. So it is important, it is necessary, it is mandatory to do that for every patient who has at least one implant. But we have the right and good compliance from the patient. The literature, unfortunately, tell us that we have lack of compliance, but not only for the patient, but more for lack of information. So for our impossibility or negligence sometimes in not giving sufficient and deeply and precise information about the importance of the supportive therapy, the compliance, and the compliance also at home. So we need to work more on that aspect. And so we need to check. We need to make clinical examination every time we visit our patient for a recall appointment with one or more implants. We need to use these instruments. So we need to use the probe. And it is not important that if we use the stainless steel probe or the Teflon probe, but we will see that in most part of the case we need to have a flexible instrument to approach those kind of concave emergence profile or different framework or over contouring or cantilever to explore the soft tissues and to identify if we have some sign of inflammation. And when we use the probe, we need to know exactly where we are, so where we are placing our probe, and which are the difference between the soft tissues around a tooth and around an implant in terms of these parts, so the supracrestal soft tissues. Because around a tooth we have a very complex and tight and very well attached fibers on the connective tissues who guarantee a very strict seal, a barrier, an epithelial barrier, but also a connected barrier to the penetration of the bacteria. So horizontal fiber, circumferential fiber, dentogingival fibers, bone dental or bone root fibers, dental and gingival or transectal fibers, a lot of these, and really attached on the cementum or on the enamel if we are talking about epithelial attachment. But if we look at the implant, we don't have the same seal. We have a seal, but not so tight, because we have some fibers just parallel and circumferential around the implant, very close to the titanium of the abutment, but not with a biological attachment. So we have a tight contact, but not an attachment. So the capacity of this seal to be effective against the bacteria that we have here in the sulcus is not the same. And the second difference, another important difference between the tooth and implants is the vascularization. So here we have at least three different vessels from the bone, from the periosteum, and from the ligament. But here we have just the bone and periosteum. So if we have and a very thin vessels, without anastomosis between them. So we have less nutrition, we don't have the ligament, we have less capacity to defend and stop the aggressivity of the bacteria, the biofilm, and the inflammation. So we have a faster progression of the pathology around the implant. And this is a microscopy of an histology around the supracrystal soft tissues around implants, and you can see some fibers, connective fibers, parallel to the implant, some circumferential, and some who try to attach to the implant but are not able because we don't have a biological structure to make a real attachment. So for that reason, we need to take in mind that when we use our probe, we can't use the same pressure. So we use around tooth. So 0.25 Newton, it's too much. It's really too much because it is demonstrated that if we use this kind of pressure on implants, we increase the percentage of bleeding on probing up to 13.7%, compared to 6.6% if you use the same pressure around a tooth. So the authors recommended to use a maximum 0.15 Newton as the pressure using your probe in the sulcus around an implant to avoid to create the iatrogenic damage or some false positive bleeding on probing. And where we need to put the probe? Of course, just in the free sulcus when we have an healthy implant. So in a condition where we don't have during the visual inspection redness, inflammation, different colors, and pain referred from the patient, or separation on pressing on the gingiva, we need just to check very, very slightly the 1.5 millimeters of free sulcus with the right inclination of the probe, and not try to go down to reach the bone, because in that case we create a problem. We open a big space and we create a damage, histological damage. So what we explore with the probe is just the free sulcus of the biological width. What is the biological width around an implant? Those 3.64 millimeters composed by 2 millimeters of epithelial attachment and 1.5, 1.7 connective tissue portion. And this portion is maintained in the right position if we have a very thick biotype, but we have a position of the connective tissue on the first threads of the implant if we have a very thin biotype, because the nature, the biology is created to have those part of soft tissues. So if we have the space at the beginning of the surgery, well done. But if you don't have, we need to place the implant a little bit more subcrestal to avoid a bone resorption to create the space for the soft tissues. But anyway, what is more important, and to understand and how we conduct us in how to use our instruments around the implant is how we can have an equilibrium, a balance between the biofilm here accumulated and the connective tissue here. So what is a mechanism who stop the penetration of the biofilm more deeply? Is the inflammation that you can see here, a lot of infiltration of lymphocytes and polymorphonucleated cells try to maintain this kind of balance. So if we look at the Cristiano Tomasi work on the microscopy on the SEM, he can show us that we have a different zone with the biofilm accumulation, and here in the first part of the implant, so in the free sulcus, then we have a clear area, so without any accumulation of the biofilm. And then some epithelial cells to try to attach on the implant, on the titanium, and then the connective fibers. So this area is due to this kind of defense guided by the inflammatory cells. So clinically, we are talking about the transmucosal tunnel or mucosal tunnel, and we need to try to maintain this tunnel free of pathology and very healthy, and we need to try to maintain this thickness the surgeon tried to create during the surgery or after the surgery. And dental hygienists are very important in this rule, fundamental for this rule. Because if not, we arrive to those kind of situations of bleeding or separation on implant that are okay from a bone point of view, but not okay sorry from a soft tissue point of view, because we have biofilm in the first part, and we have allowed without any supportive therapy and without any domiciliary care to the biofilm to go deeply and to disbalance the equilibrium that I was talking before. And this is a clinical video where I would like to show you that when you are checking an implant, especially in an aesthetic area, with the modern convex shape and parallel position of the fixture, you need to use the probe in a different way, not like you do around a tooth, so parallel to the root, because it's impossible to explore those parts. You need to go almost horizontal, or at least at 45 degrees, trying to check the healthy or the inflammation of those soft tissues. Because if not, if we leave this, because with the eyes, with visual inspection, we look that everything is okay, but we don't use the probe and we don't identify the bleeding on probing and we don't treat the mucositis, the next step will be bone resorption and severe periimplantitis, and it's very, very, very difficult to treat those kind of periimplantitis later. But we know also that we need to fight with other risk factors that are not just not only connected or related with the microbes, with the biofilm, but also with the implant and the adverse loading, for example, but especially I want to focus on this, so this cement excess that sometimes in those kind of prostheses that we try to avoid because we want to work with the screw crown to avoid the problem of the cement, but in the most of the cases of this kind of restoration, we have residual of cement, and the residual of cement like this create those kind of bone destruction and soft tissue inflammation, and it's really difficult to find in the x-ray those kind of residual of cement, because if it's here, so mesial or distal, you can look in a bidimensional x-ray, but if it is on the buccal or palatal part, it is impossible to see in the x-ray. So you need to search to have the right instrument to disgregate this residual cement, because if not, it's a foreign body, and you will have biofilm accumulation there. So you will have an infection and an inflammation, as you can see in this case that we solve. Yes, with a treatment, removing the crown, removing the residual cement with the right instrument, and instructing the patient, but we want to avoid those kind of situations. And if we look to the risk evaluation, the IDRA, Implant Disease Risk Assessment, that those group of authors published in 2020, we can see that we have this part and this part of the risk assessment that are very interesting for us, because they support what we do every day with our GBT and with our instruments. So the first is the supportive compliance to the supportive periodontal supportive therapy. Patient who doesn't want to be compliant and they don't come back to the recall at all, they have a very high risk to develop a peri-implant complication in the future. And here we have cement excess. If you have cement excess, you have a high risk of peri-implant complication, but even more, the poor fit or not cleansability of the work is a big problem. So what does it mean? That the cleansability of the implants and prosthesis on the implant is very important, but if it was not done from the clinician, the surgeon, and the prosthodontist, we need to find the way to have an access to the transmucosal tunnel and disgregate the biofilm, remove the calculus if there are any calculus, and remove residual of cement if there are residual of cement there. And how we can do, and this is the question, and this is what I want to show in the second part of the webinar. But before, I want also to share with you this fantastic picture from Gomez Meda publication, where he described the different zone, the different area in the transmucosal tunnel, the C, B, and E, that are different in terms of composition histologically. So this is the crestal bone stability due to the connective tissue. Then we have the non-keratinized epithelium here. And then we have the stratified squamous epithelium in the sulcus. And those parts corresponding to different kind of material in the restoration. Here in the C area, we have a titanium base, almost ever. In the B area, we have zirconium in the most of the case, and in the static area, we would have zirconium or ceramic. So we have three different materials in three different areas that we need to clean, we need to maintain, and we need not to alterate in the shape, in the roughness. It is not an easy work for a dental hygienist. So we need to really know what we can do and what we can use on this kind of materials. And this is in 3 colors, the 3 different areas: ceramic, zirconium, and titanium base, with a different shape. It's something that creates another difficulty for us to have the accessibility with the conventional instruments. So these kind of shapes, no? This convex profile here to support the soft tissues and give the aesthetic that it's good, it's very good, it's beautiful, but it's difficult for us to clean, to check, to maintain. So we need to find a compromise, right? So what is the prevention of this problem? The first question is, we have understood that we have different profiles, different materials, and different depth of the mucosal tunnel according to the different phenotype or position of the implant in terms of bone level or subcrestal level. And so which professional tools we need to use? And this is the most important question, I think, today, this evening. So we have different instruments: the Teflon curette, the carbon curette, the titanium curette, the stainless steel curette as the manual instrument and scaler. We have ultrasonic and sonic tips, the PIC tip, the carbon tip, the titanium tip. We have the airflow, we have the perioflow with different version and different powders, erythritol powders, glycine powders, bicarbonate powders. So we need to choose what is the best. And I want to show you the history of the instrument here. This poor patient who stayed there, and I was showing to the student what we can do depending on the instrument that we have in our office. So the stainless steel curette scaler are appropriate? I think no, absolutely no. Do you think that the rubber cap are appropriate for the maintenance? If you don't have anything better, it's a little bit better than the stainless steel manual instrument. But also these instruments are not effective because they don't reach the point and are really damaging on the surfaces. And this is even worse. So the stainless steel ultrasonic instrument on ceramic, zirconium, and titanium, and in the soft tissues. So it's the worst that you can do because you alterate completely the surfaces. You create roughness, scratches, and with the old instrument, and this is the PI, our PI, it was very difficult to go into this thin and very complex shapes. So the new PI, PIEZON Max, it's something really interesting and smart because the shape is so thin that we can really go wherever we want, and also we can use the tip in a different way, not in a parallel or vertical position as it is recommended because it is an ultrasound. So the linear movement is used to be used in a vertical position, parallel position, and then a little inclination of 30 degrees to be more effective. But here you need to remember and take in your mind that you have a convex profile, at least 40 degrees of emergency profile. So you have another inclination of the surface that you need to clean and disgregate. So it is like you are using your tip in a right and recommended usage, because you are not working in the vertical position of the crown, but in the horizontal position of the crown. But we know also that our loved airflow with erythritol powder is the first instrument that we need to use before to go with other, in particular before going with the PIEZON Max tip, because we can really deliver in these shallow sulcus the powders without create any damage on the materials, prosthodontic materials, implant materials, soft tissues, and we can move up a little bit the soft tissue and deliver the powders all around, and it is effective and safe. It is not needed in this situation, the PerioFlow nozzles, because it's too tight, the soft tissue, and we don't have more than 5 millimeters or 4 millimeters pocket. So who is new in this field, please don't use the PerioFlow when it is not recommended. So some supplements like the chlorhexidine gel in a formulation of a slow release or controlled release gel, it could be indicated at the end of a treatment of a mucositis to increase the effect of the mechanical debridement with powders and or with the PI tip. This is a model that I use with my student to explain how to use the PerioFlow nozzles when you have more than 5 millimeters pocket. So when you have a perimplantitis in the most of the case, but sometimes mucositis with very deep subcrustal of tissues without any connection because you have lost the equilibrium, the balance between biofilm and inflammatory response, and so you can go and reach the bottom of the pocket and be effective also between the threads. But if you need to remove the biofilm and or the calculus or residual of cement in the first 2-3 millimeters of the sulcus, the most indicated tip is this: when you are not able to be effective with the airflow, because if you have just biofilm in 2-3 millimeters sulcus, you can just deliver the powders. But if you have the suspect or you can see with your magnificators hard deposit or the cement, you need to use also the ultrasound. And this is the insertion of the tip, and you need to inclinate a little bit, 30 degrees, to have the linear movement and to be effective. Okay? If the profile of the crown allow you to use it that way. If not, you need to inclinate more the tip to be effective in the horizontal emergency profile. This is another view of the tip, and there is another advantage of the tip compared to the previous one, because you have everything in one, all in one, and you can use your dynamometric key to close, to fix the tip on your handpiece, and it is easy to use and very thin, like a probe, so 0.5 millimeters, less than a probe, and it is really, really, really important for us, for the accessibility. How we need to use, what is recommended in use, not more than 30-40% of power, because believe me, it's really effective in terms of vibration. So I use always 30% on teeth, veneers, implant, crowns, whatever. It is really sufficient, this kind of power. Water, 78%. I suggest not to increase the temperature, to be sure not to heat the tip and provoke maybe some wear more quickly of the tip. And you need to change the tip when you lose the 2 millimeters of the bottom of the tip, and anyway, after maximum 25 treatments, it is recommended to change the tool. And after 1000 processing cycles, it is recommended to change the instrument holder and the combi torque to be sure to be really effective, precise, and not create any kind of damage for the wear of the instrument. And compared to the old instrument, we really changed the work, because do you remember how much was difficult to place properly the peak tip on the chuck with the right length, and then in the end piece, and then the also at 10%, 100% of the power, the effectiveness on the vibration was not sufficient, and the size was too big, so it was a problem with this kind of tip. But now we have those kind of accessibility. Also, in very thin biotypes, you are able to penetrate and disgregate the calculus or residual of cement without creating any kind of damage or alteration on the zirconium or ceramic restoration. So you are very safe. And really, when I used the first time this tip, I thought, oh my God, finally I have something effective, good, and safe. And a little bit more flexible than the previous peak tip, because we have carbon, 30% of carbon inside, without with the together with the polyether ketone. So we have a little bit softer tip and flexible tip that is even better than before, for different reasons. And this is a video where, after using the airflow during a DVT on a patient with implants, and especially with this implant in peri-implant mucositis, we needed to try to remove a residual of cement in the buccal part of this crown, very deeply collocated, because we were working with the microscope, so we were able to see, to identify this probably provisional cement, and working with 30% of power of with this PI PIEZON Max tip, we really was effective in reach the right point and remove this kind of terrible risk factors for a future peri-implantitis around this crown in a young man, 22 years old, who had a genesis of the lateral incisors, and they put this implant. And here I was comparing the old peak tip with the new PI tip, and with the tip of the topical antibiotic, the applicator of the topical antibiotic. You are able to find the difference? Yes, I think that now you are convinced that the new tip is fantastic, and it's something that finally we have in our hand to help our patient to maintain healthy their implant, to treat the mucositis in a very effective way, and to remove the cement after the cementation if you use this kind of prosthodontic prosthesis restoration. So I think that this is sufficient, but I want to leave you with this video that is important for me, because what is not easy is to understand how to check the length of the tip. So you need to use this tool. You insert the tip, and if you don't look the tip in this part, you need to change the instrument. Sorry for my problem with my throat. And what is not so easy is to change the tip, to remove the tip and put the tip. So I would like to explain you through this video. So this is fine. You see that there is the tip here visible. Okay, it's okay. If not, you need to change. These are the components of the tool. This part you have right disconnect or connect. If you want to disconnect, you need to insert the tip with your hand, and then you need to push out the tip with this other component of the tools. You need to screw until it touches the tool and it removes the tools. Okay, softly and gently, and that's it. And you remove the tip. And then you need to change to connect the tip. You need to remove this part and this one. So you replace the new tip on the holder, and then you need to insert the holder and the tip in the connecting area of the tool, and again press push the new tip with the second component, screwing in and pushing until it touches the tool, and that's it. So that is done, and you are ready to start again with your treatment. That's very, very, very important. So check your tips and change the tips when they had lost the 2 millimeters of the bottom on the bottom of the tip. Okay, so please do this to be effective and safe on your patients. So with this video, I want to say hello to all of you. This is my website. This is my personal email. You can find me in Instagram or Facebook with the same name, Magda Mensi. So if you want to leave me some comments, some question, also by email or by the social networks, or I'm here for the discussion now, for the Q&A session. And I hope that this short webinar during the evening, it could be useful for you as the first clinical experience shared with you. And I hope to have your feedback and feelings, because it's important that we work together to improve every time the possibility to have the best instruments for the maintenance and treatment of peri-implant complication, because it's a topic that it's one of the most important in dentistry and of the present and also for the future. So I'm here for the Q&A session. Bye-bye, and thank you very much for your attention. Okay, so hello everybody, and thank you to be here with us and to follow the webinar. This is something really new. You know that this instrument, the PIEZON PI Max, is something that EMS has introduced in this last month. And I had the great opportunity to test the tip in my private activity and at my university on my clinical cases of healthy implant and mucositis, and surgically and not surgically. So I can tell you something more about that after this the webinar that you heard. And remember that the PIEZON PI Max is something that you use after the steps of the GBT protocol. So it's something that you use in the GBT treatment on implants. So of course, after the assessment, the right assessment, and this is a chapter very important when we talk about implants, because the probing that you need to do is very delicate, not more than 0.15 Newton, to not create damage on the attachment, epithelial attachment. And of course, you need also to look at the inflammatory aspects of the soft tissues and try to press on the mucosa to see if there is some suppuration. So it is something specific, the assessment. You need to follow this step and so apply the disclosing plaque agent and educate your patient at the beginning of the treatment on the oral hygiene extraction. And this is another specific chapter for the implants, because you need to clean different profiles, need different frameworks, different kind of prosthodontic restoration, fixed cemented restoration, screw retain restoration, full arch restoration, bridge, single implants in aesthetic area, in posterior area. So it's very challenge to choose the right instrument. So you need to dedicate a lot of time to this part. And then you of course, you need to remove all the supragingival biofilm with the airflow and the erythritol powder, with the plus powder, exactly as you do with the GBT on teeth. You do the same on implants, and you also use your airflow into the sulcus up to 3-4 millimeters on the implants. And with these, you can also move a little bit the mucosal peri-implant barrier and try to look into the sulcus, the implant sulcus, if you have an healthy implant, and try to identify if you look some residual of cement or some hard deposits. And in that case, you need to go to the next step. So the use of the PIEZON PI Max to remove the hard deposits or to remove the residual of cement. Or you can use the PI Max, PIEZON PI Max, to make the debridement of the biofilm if you are not able to reach some areas, particular areas with the perioflow. If you have 5 millimeter pockets, you can try with the PI Max. And then, of course, you need to check everything, to use your magnification, your lights, your probe, your explorer, to check your work, and you need to make to schedule a right recall for the patient with implants according to the risk assessment, the implant disease risk assessment, of course. But normally we recall all the patients with implants every 3 months. So coming back to your questions, I see that most of you are interested in the use of the PIEZON PI Max on the threads of the implants in a non-surgical treatment and in pockets exceeding 3 millimeters. So this is a very interesting question, because you need to start from the idea that the biological width around an implant is like 3.5 up to 3.8 millimeters. So from the bone crest, you have 1.5 millimeters of connective tissues fibers, not without any attachment, biological attachment on the abutment, but in contact with the abutment, creating a sort of a seal, but not a real attachment. Then you have 1.5 millimeters of junctional epithelium. And again, you don't have any attachment by hemidesmosomes. Just some cells try to create some kind of very weak contact with the abutment, but there are no two biological surfaces that can create a real attachment. So of course, you have 3 millimeters of connective tissue and junctional epithelium, very, very, very close to the abutment, but you have a micron space, like 25, 55 microns. And in the last part, the most cornal part, 0.5 millimeters up to 1 millimeters over the free sulcus, you have the space to place your probe, and that you have the biofilm just there, because normally in an healthy situation you have a balance just below this area due to the inflammatory response on the connective tissue. So in a normal situation, you don't need to go deeper than 1.5 millimeters. And if you have calculus there, you can use the PI max. But if you have 2 or 3 or 4 millimeters, you have, of course, a mucositis. And you are working on the abutment, on titanium or zirconia material. And it is difficult to have a very big deposit of calculus, but if you have, of course, the best choice is the PI tip. If you have more than 4 millimeters, you have a perimplantitis, of course, or a beginning of perimplantitis. And if this perimplantitis is associated with an horizontal bone loss, what is recommended is to use the perioflow nozzle to remove the biofilm, to apply some antimicrobial gels, but in specific, some topical tetracycline controlled released antibiotic to control the inflammation and to increase the detoxification of the first thread of the implant. And if you are able non-surgically to see or to detect some calculus there at this depth, you can try, of course, to use the PIEZON PI max. As you can try to use the old PI tip. You can't use the stainless steel tip, and the titanium tip are not indicated because if you are able just to detach the calculus and not stretch the implants, it's okay, but it's impossible without a flap. So what I recommend is to try with the tip, but what could happen is that you will not able to use properly the PIEZON PI max, because it's difficult when the pocket is more than 4 millimeters, so like 5 or 6 millimeters, to use the linear movement with the right inclination of the tip to be effective with the last part, with the last 2 millimeters of the PI max. So what happened is that you really damage the tip and you are not effective. So I know that it's a difficult answer this, and a difficult question as well. But when you have this kind of defect, normally there is the need of surgery to regenerate, to recreate the bone where you lose the bone, because if not, for the rest of the life of this implant, you will have a pocket, because there is no attachment, direct attachment on the titanium. So it is recommended to prepare the patient with the GBT on implant, and then go into the GBR techniques on implant. And we can use the erythritol powder with the open access, so with the flap. And also I had used the PI tip on the threads of the implants, because sometimes you need to remove some deposit with the open flap. And then you can use the GBT to maintain the patient periodically with after the surgery. If there is an horizontal bone defect where the GBR is not possible, so you can't recreate the bone around this kind of defect, of course you can and you need to be more aggressive on the pocket. So you can use also the PIEZON PI Max on the to degranulate soft tissues, and you can use also a manual instrument on the internal epithelium of the pocket to try to obtain a thin mucosa, and so a contraction, a retraction, a recession of the soft tissues. And at that moment, you close the pocket and you have the exposed thread. And in that moment, you can use the PI tip supragingivally, and there are no problem if you create some damage, because it is not in the bone, not in the soft tissue, but in the oral cavity. And the patient can be educated to clean these threads with the right tools at home. So I hope that can help you as a suggest and tips and tricks. So let me see if there are any other question. Is the only indication to use the tip in conjunction with the airflow if there are hard deposits present? Many thanks. Yes, of course, if there are hard deposits, the best combination is airflow and PIEZON PI Max. Nothing else, because we need to, if we don't want to expose the metal parts in the oral cavity, we need to maintain the smooth surface of the polished zirconia and titanium of the abutment with our instruments to disgregate the biofilm. So the only instruments that can do that are the erythritol powder and the PI Max. No other instrument, because if not, you will create scratches, roughness, and different surface where the bacteria, the biofilm, is embedded, and it will be more difficult in the future to control the infection. So this is very important, not to be aggressive on the materials, and also on the ceramic, of course. Don't remember that the GBT is the best treatment and prophylaxis approach for the veneers, for the aesthetic crowns, of course. Thank you. Is there recommended post-op evaluation followed by instrumentation and or antibiotic therapy for mucositis? Okay, yes, now I understand the question. So normally when I treat a mucositis, I check my patient after 2 weeks as the gingivitis. So of course you will have a healing, a complete healing after 2 weeks. So the time to have the healing of the epithelium. But it is important to remember that if you have a screw retain crown and you have a mucositis, if it is possible, unscrew the work, because with the airflow you can also detoxify and clean the abutment, the crown, the screw that is contaminated, and of course the platform of the implant and the soft tissues. And so this is the only instrument that you will use in this kind of treatment. So if you have your doctor there and you are a dental hygienist, please ask for the removal. If not, you can do, of course, by yourself, non-surgically, but it's much more effective with the removal, of course. And in that case, you can also look at the abutment surface, and if you see some hard deposits, you can use outside of the mouth, perfectly seeing the tartar, the PIEZON PI max, to remove very quickly the hard deposit. Okay, if you don't obtain the healing, of course you need to apply some topical antibiotic and check your patient after 2 weeks more. And if it doesn't work, there is some problem in the shape of the abutment, in the material used, in the emergency profile. So we need also to cooperate with the periodontist or with the prosthodontist to remove the iatrogenic cause. Is this a procedure that can be done a regular recare appointment, or disease for implant mucositis? This is a very good question. Yes, you can use the PIEZON PI Max for the regular recare appointments, but remember that if you have an healthy implant, normally you have 1 millimeters of free sulcus that you can clean perfectly just with the airflow. And if with the airflow, after this step, you see or detect some hard deposit, you can use the PIEZON PI Max. This is the reality. Because if in the recall you have more than 1 or 2 millimeters free sulcus, you have a mucositis. So this is a treatment, not a recall appointment. I hope to be clear in that. What method do you use to teach the students and colleagues on how much pressure is 50? Yes, that's a good question. I use the calibrated probes. You have these plastic probes with a special part where you can check the Newton you are using with the pressure, so they can start to feel how much correspond 15 Newton according to their hand. And then they can start to use the normal probe because they are able to identify this light pressure. It's a very light pressure. Okay, thank you for the animation, and you will be very successful. Hello from Rio. Let me see. Thank you for very much. In addition to your project, to use diode. Okay. So they are asking me if after the GBT on implants, it could be useful to add the laser diode or the photobiostimulation. So we have a lot of evidence in the literature that there are not so much benefit, not clinical benefit adding the laser. And we have a lot of publication by Frankfurt about that, and he's one of the most important experts on the laser. A different thing is the photodynamic therapy or the use of probiotics for the treatment of the mucositis. In that case, we have some interesting clinical evidence that if it is not sufficient, the mechanical debridement with the GBT implant treatment, you can add a cycle of Lactobacillus reuteri administration for 15 days, and then 3 months of washout, and then other 15 days and 3 months of washout, and or the photodynamic therapy. I have some experience with the elbow treatment, so with the phenothiazine, and the laser, the cold laser for the photodynamic therapy. But I use this just if the GBT on implants it doesn't work. And to be honest, in mucositis, it's not necessary in the most of the case. How many months after the prosthesis is screwed on should we start to care for the implant? This is another good question. Thank you to this colleague. So remember that when you screw the prosthesis, from that time, start the time for the maturation of the epithelium and the connective tissue that you damaged a little bit when you unscrewed the healing abutment. So when you put your definitive restoration, you need to give 12 weeks, so 3 months, to the soft tissue to be stable, and then you can start with the recall appointment. This is my suggestion, but not my suggestion, the suggestion that come from the literature. And with this, now there is a question about the concentration of the chlorhexidine that I used, or that it's been that it's recommended to use in the mucositis treatment. There is just one product that I know that is a chlorhexidine slow release gel, because we need this slow release or control release gel, because the crebicular fluid is able to remove any kind of gel if there are not hydrogels in 10 minutes, 12 minutes. This is proved by Goodson in the 80s. So you need some specific product, and I know just one product where we have dichlorhydride chlorhexidine and dicleuconate chlorhexidine 0.5 or 1% in hydrogel. And this allowed to release the chlorhexidine for 5-7 days. For the topical antibiotic, I recommend the doxycycline. Not in any country, in every country it is available, unfortunately, because it's very effective. But I use the doxycycline in polylactic acid, polyglycolic acid, resorbable hydrogel to have a controlled release antibiotic, just to treat the acute and severe periimplantitis before to make a session of GBT on implants, and immediately after, so to administration of the topical antibiotic. Or you can add this topical antibiotic immediately at the end of your GBT treatment on mucositis with suppuration, if you are not able to remove the prosthetic warts. Because if you are able to unscrew or uncement the crown, normally the GBT on implants with the combination of airflow and PI Max, PIEZON PI Max is more than sufficient. Okay, so let me see. Thank you so much for your helpful presentation. So, okay, now we finish with the question and with the answer. I hope that this webinar and the discussion it could be useful for you for your daily practice. And if you want to ask me something more, you can find me in my website, magnamensi.it, or in my email, personal email, magnamensi.gmail.com. Okay. Thank you for your attention. Thank you, EMS, for this opportunity. Greetings to all the team in Neon, Mr. Brunner first, Neha, and all the team. Thank you so much. Goodbye.